Hi, I'm Anna Gosline from Blue Cross Blue Shield of Massachusetts, and I'm joined by Vicki. And so we're here to tell you a joint story about the experience of Massachusetts and global-based payments and how they provide both opportunities and really challenges in financing high-quality care for people with serious illness. I'm going to start a little bit about giving you sort of the landscape in Massachusetts of global payments and a bit of the history, talk a bit about Blue Cross of Massachusetts program, our global-based payment, and then Vicki's going to talk about the program that these kinds of contracts allowed her to create and finance at Mass General. I don't know if this clicker works, or if we should just say, next slide. Okay, so this is a bit of a busy slide, but it sort of shows you two different snapshots of the prevalence of global payments in Massachusetts. The first one, the blue bars, is a comparison of the penetration of the Medicare Shared Savings Program in Massachusetts in different major regions in the country. Massachusetts is by far and away eastern Massachusetts, the highest penetration of Medicare beneficiaries attributed to a Medicare Shared Savings Program in the country. And that number actually doesn't even include the significant number of beneficiaries who are attributed to a next generation ACO, of which Mass General and Partners is one. So it's even higher than that. On the commercial and Medicaid side, it's you can see on the commercial side it's even stronger. It's about 40% of commercial members in Massachusetts are cared for under a global-based payment. Medicaid is a little bit further behind, but we've actually been seeing those numbers grow recently, and unfortunately, you don't know that that means those three different colors are 2014, 15, and 16. Next slide. So, oh dear. Can I go forward again? Can you just click? Yeah, keep on clicking. Ooh, one more back. Yes. So this is a bit of a history. Obviously, those numbers didn't appear overnight, and the progress towards global payment adoption in Massachusetts has been happening for a long time. 2006 is the first date on this chart, and what I probably should have put in there is that was actually the date that our universal coverage law passed in Massachusetts. And that's significant because even though within about 18 months we basically had everyone in the state covered, that put significant cost pressure in a state that was already the highest per capita spending state in the country, which by the way means that it was the highest per capita spending place in the world. And so at Blue Cross, we knew that the largest contribution that we could make, both for cost and quality, was to change the way that we paid for care. And you can see that started developing this global-based payment model that was introduced in 2009 and 2007. At the same time, MGH, which is obviously where Vicki is coming from, started experimenting with these kinds of models too by participating in Medicare care management demonstration project for high-cost beneficiaries. And we sort of tracked together in a lot of ways. The first full AQC contracts, alternative quality contracts, rolled out in the HMO market, which is about 50% of the commercial market in Massachusetts, happened in 2009. Partners, which is the overarching system that MGH is part of, joined in 2011. They became a pioneer ACO in 2012. I should say that Blue Cross's AQC was one of the sort of inspirational concepts that actually led to the pioneer ACO. They sort of borrowed a lot of the elements. By 2013, we had about 85% and then growing to more sort of 90% of our physicians in Massachusetts contracting under the AQC model. In 2016, we expanded it to PPO, and in the same year, Partners joined the PPO model as well as became a next generation ACO under Medicare. Next slide. So click all the way through. So this is just a little bit. I'm not going to talk very much about the actual AQC model itself, but because I think most have a pretty reasonable grounding of what an ACO kind of looks like. Global-based payment covers all services, upside and downside risk. Always a huge emphasis on quality. I think we heard how important that is in some of the earlier discussions this morning. Ambulatory and hospital measures, very significant earning potential involved in sort of achieving performance on those. And as the financial model changed over time, it also meant that systems that performed better on their quality measures were eligible to receive increased amount of their shared savings and pay back less if they had a shared loss. Next slide. So the results under the AQC have been pretty impressive in terms of quality. You can see that the top bars are the AQC groups and the bottom bars are sort of national comparisons over the same timeline. And especially I think what's important is to look at that last frame, which is adult health outcomes. And time when in national stagnation, AQC groups really saw significant improvements in things like controlling blood pressure and controlling cholesterol. Next slide. We also saw significant cost savings. So this is, both the previous slide and this one grew out of a series of evaluations that Harvard Medical School did of the AQC, did an evaluation every year for about 4 years, and found accelerating medical claims cost savings. And this most recent paper that was published covering the first 4 years of the program compared to controls out of state. We actually had to start comparing to controls out of the state because the program was so large we could no longer compare to controls within the program. So the question was always, these results were, extraordinary in lots of ways, but focused on a commercial population where the predominant issues were kind of chronic conditions, diabetes, hypertension, and the number of people with serious and advancing illnesses in a commercial population is actually relatively small on a percentage basis, which sort of asks the question, does it provide strong enough incentives and really enough expectation of shared savings in order to invest in creating really robust programs to address people with serious illness? I have the next slide. So our kind of gamble was at the same time recognizing, even though our own serious illness, members with serious illness probably in and of themselves wouldn't create enough shared savings, even though we've all seen the literature demonstrating what kind of home-based palliative care and palliative care can do in terms of ROI, but we knew that most of those systems were also taking Medicare risk, which led us to sort of think more from an infrastructure perspective and a sort of a system building perspective than sort of any dedicated payment financing to begin with. Because again, the whole point of the AQC and global payment arrangements like that is it is providing those incentives to think outside sort of traditional fee-for-service structures and be able to sort of do things that aren't maybe technically reimbursable. So a huge part of our work here has been a partnership with Ariadne Labs, and we talked about that before. My boss Andrew Dreyfus is on the board of Ariadne and started seeing the really interesting results coming out of the clinical trial that they were running on trying to train doctors to have better primary palliative communication skills. And it wasn't just about training. There was a question asked earlier. It's not just about training. It's obviously about the systems and supports that are built into that in terms of changes to the EHRs, changes to the sort of triggers to remind them to have conversations. So all that kind of works hand in hand, and we sort of funded 2 different systems in Massachusetts to implement this program, and we're expecting about 4 more to be implementing it in the next cohort. And this sort of works hand in hand with the other sort of bucket I'm going to touch on, which is our policy and community bucket, which is, along with Ariadne Labs and the Conversation Project, which I'm sure many of you are familiar, founded a statewide coalition in Massachusetts that now has about 85 organizations all working together to improve care for those with serious illness. And initiatives that have grown out of that have been things like a collaboration among our health plans to talk about alignment on quality measures for serious illness. And we by no means have the answers, but I think that we understand the power of payers talking together to send similar messages into the marketplace. And even those conversations had grown out of a series of meetings we had with our provider community to understand how quality measurement would feel most meaningful to them. And that was really in the context of the kinds of relationships that we built through a global payment arrangement. So I'm going to turn it over to Vicki, and she's going to talk about what these types of payment programs have been allowed her to do, and then we're going to talk a little bit about what we've learned together at the end.
Awesome. Thank you, Anna. Next slide, please. Yeah, great. So, the story that we heard today about Ralph and Patricia, I think, is something that all of us in palliative care see all the time, unfortunately. And when we were at a stage in growing our program and seeing that we had a huge inpatient palliative care consult service, and I was seeing patients like Patricia all the time who were so sick that they couldn't engage in a longitudinal medical relationship with their provider, and they weren't hospice eligible, and we were really failing them. I was failing them. We were failing them as a system. And at that time, I went to Tim Ferriss, who is our head of population health management at Partners, and he was really, because of these payment models, able to think about new ways of delivering care. So he was working on a partnership to build primary palliative care training at the Brigham, using Ariadne's serious illness conversation. And we started talking about a model like this, a home-based palliative care model. And he said, let's try it. These patients are falling through the cracks. They're not hospice appropriate. Let's figure out how we would do this. So we built this program, a home-based palliative care program that's embedded in our ACO. And I should say a little bit about what population health management looks like at MGH and at the Partners level, because it really allows us to do what we do. So our high-risk patients are all assigned a nurse care manager who drives all of their care. and in that was able to identify whether these patients had unmet palliative care needs and refer them to a home-based palliative care program. These nurse care managers also have a lot of other resources at their disposal, like psychiatry, like pharmacy help, like community resource specialists who have slush funds when, if somebody really does much better if their air conditioner is in with their COPD to avoid admissions to the hospital, they can pay somebody $50 to put that air conditioner in the summer. So those kinds of things were really important for us as we were thinking about how we were going to build this program and be able to piggyback on the good work that they were doing. So the population of patients, as I said, were identified as patients who had unmet palliative care needs. I think what we have found over time is that these patients fall into three buckets. One bucket is a group of patients for whom hospice should have been employed months, probably several months earlier, and that didn't happen either because the patient was too ill to actually be able to be engaged in a conversation with the provider who knew them, or the provider who knew them didn't understand that they were actually hospice appropriate, or they were resistant and actually needed subspecialty level palliative care to be able to make that transition. We typically see patients in this bucket 1 or 2 times and they transition to hospice. The second bucket of patients we see are folks who are really symptomatic, typically multiple chronic comorbidities, heart failure, COPD. We get them comfortable with our home-based palliative care team, and then they transition to either the third bucket or the first bucket. It all depends where they are on Joanne Lynn's curves. Like, the question is, are they on their final bump or not? If they're on their final bump, then we help have the conversation and transition them to hospice. The third bucket are folks for whom it's not their time yet, and we're not sure exactly when it is, and because we're not so great at this. When I went to Tim and said, let's do this program, and we had looked at the Kaiser model in Lehigh Valley, and I said, looks like average length of stay is 6 to 9 months, which is true, except there are these people who live longer, and they aren't hospice appropriate, and they still can't get in to see their primary care doctor. And so that's the third group of patients. And I would say most of those patients, it's a prognosis of about a year, but we now, 4 years into the program, are noticing, that we have a cohort, probably 15, 20, mostly women, over 90, multiple chronic comorbidities, and significant cognitive impairment. And I went to Tim and I said, hey, should I discharge these people? That seems crazy. Their yearly mortality is well over 70%. And so we've decided, yes, we should keep these on, but when we think about it from a financing perspective, I have to think about right-sizing the care and making sure that the care is appropriate. And do they need a nurse practitioner every other week seeing them? Probably not, but we need to keep that care plan enforced. So that's been an important piece for us to think about. We'll go on to the next slide. So we've done 2 evaluations of this program, have shown about a $1,300 per member per month cost savings in the last 6 months of life. When we look at sort of what are the drivers of that cost savings, it's decreased number of days in the hospital, but decreased cost of those days in the hospital as well. Also, we're shifting how long patients are on hospice. We have many fewer patients who are on less than 7 days, more who are in the 3 to 4 week kind of time span. So the net benefit to the ACO for these patients is a little over $2,500, which is not a huge margin, which is why it's really important to think about how we're going to manage these different populations of patients. What's needed for that person who's incredibly short of breath, and what's needed for somebody who's plugging along until they have that next aspiration pneumonia are 2 different models. And we have to be nimble and think about that. We'll go on to the next slide. So this is our geographic area. We've just now, after this evaluation, expanded to cover most of the greater Boston area, sort of around 128 with people who are familiar with this area. I would say the geographic issues are huge. It's really a big deal. And how do we make sure that we've got the right people in the right places? It is definitely a tricky piece. I would say one other thing that's really important, somebody earlier today mentioned, can we just expand hospice? And I think we really have to think about it, because I would say these patients are sick as snot. They are really, really sick, and they need a really good internist or geriatrician, because the goal isn't comfort yet. We're still going to treat their hypertension. We're going to treat these other things. And so I think we have to be really careful and clear about what's the right model for different patients. Next slide. So Anna and I want to talk a little bit about lessons we've learned. You know, people always say to me, how did you get your administration to agree to this kind of care model? And I think part of the thing that's important for all of us, and Bob and I were talking about this, you need to know what keeps your administration up at night at your hospital level and at your enterprise level. And you got to go in with a plan, and with a plan that's going to be reasonable. The margins are not huge here. I can't go in asking for the moon. I have to be clear and be able to right size it. I think the other piece that's important is realizing that you have to adapt, and we're going to learn lessons. So we've definitely learned that there are going to be longer stay patients who are going to need different kinds of things and different kinds of care models. I think finally, the importance of relationships. I have to say, hanging out with Anna Gosline is one of my favorite parts of my job. And so the idea that we can think about as an academic medical center provider and leader, being able to have this really important relationship with a payer has been incredibly helpful. We bat ideas back and forth and really think through how can we work together to be able to help one another in this space. I don't know if you want to talk about some.
Yeah, and I would say the reason why this slide speaks to a lot of both of our experiences, and for us, the adapt as needed is also recognizing, you know, Global Payments put these incentives in place, and Vicki and her team at MGH and Partners have been able to establish this program. But even though the AQC and you've seen the very high rates of global payment adoption in Massachusetts, it has not pervaded across the whole state. So our sort of thinking as a payer is, you know, we thought we had these incentives in place, we're trying to put these wraparound supports, but we have to adapt and really think about potentially more targeted financing to help other systems be able to think how Vicki has been able to think, so they can kind of get their own internal cost accounting line. And that means potentially thinking about more directed payments for community-based palliative care, which is where we didn't think we were going to end up there. So, and I wouldn't have learned those lessons were it not being able to really interact with Vicki on understanding the nature of the financing that's allowed them to get where they are.
Thank you.
Thank you.